Great. Good afternoon, ladies and gentlemen. Welcome to this session. It's entitled Delivering High-Value Thoracic Surgery, Outcome, Processes, and Quality Improvement. So glad to see you here. This is a session which would actually describe the vast majority of your practice, and we hope to be able to share some good discussions about principally what determines outcome, process, and pathway, and how we can deliver high-quality care to our hospitals, institutions, and country. My name is Eric Lim. I'm a surgeon from the United Kingdom. On my far right is Mr. Andrea Billet, who's also a surgeon from the United Kingdom. And we've got Lars Gienen, who is a surgeon from the Netherlands. And we're going to go from patient to country to global. And we're going to start with Andrea to talk to us.
Thank you very much for being here and for the kind introduction, Eric. We're going to discuss about the data starting from a patient perspective. And what we know in terms of background, the chest drain practice varies widely across Europe, not only between countries, but even within the same units. Even within the different surgeons in the same units. And what we know and why the drain matters, because prolonged air leak remains one of the most important driver for our postoperative morbidity, but not only in terms of complication, also on how the patient's recovery is affected by having the drain or about the drain management. And the drain-related decisions are done every day for each patient by each surgeon. But despite this high level of decision-making, which may affect, again, the patient journey, still is very fragmented. What about the optimal chest drain size? This remains quite controversial still. What about the digital drain system, which, of course, offers advantages in terms of objective measurement of fluid and air leak? But despite all of that, the adoption is very heterogeneous if you look across not only Europe, but even across the world. And we know that the existing literature so far is mainly driven by single-center series and small randomized controlled trial. And despite all this evidence, there's no any national guidelines or adoption so our patients can follow a precise pathway. And all of us has been trained by our previous boss about how to manage the drain. There was no question. It was a kind of like a myth and a dogma that you have to learn, rather than being more like a scientific approach like we do in the other subfields of our specialty. And, those are the evidence that so far has been published. You see there are quite few randomized controlled trials about the using of suction or no suction on different level of suction. And there's no any clear evidence in favor of suction. Actually, there's more and more evidence that not to use the suction. But even when you go through this paper, you see there's also a very huge variability, how much suction, for how long you can apply the suction. So all of this is contributing to further fragment the evidence we can use for our patients. And it's the same is for the fluid output. So what is really the patient-driven outcome? Well, we always been focused on traditional outcomes: complication, duration of chest drain, volume, air leak durations, level of air leak. But then if you look specifically at patient-centered outcome, this is a key quality indicators on how you manage your chest drain after surgery. Because we know that the drain has a lot of collateral implication on your patient's recovery from surgery. And there are some papers in indication that the drain may be related with the pain score and how the patient, the postoperative pain, the number of drain, the suction, all of these can contribute to that. And when you specifically look at the patient journey, the recovery of your patients, the way we manage the drain can affect poorly the recovery, not only in hospital, but also the postoperative recovery. Because, having the drain for a longer time can delay ambulation, can reduce the physiotherapy and the level of engagement of the patient for the physiotherapy. Due to the pain, you can also have an impaired deep breathing exercise and an ineffective cough, increased fatigue, and all of these can generate other complications, such as hospitalized acquired pneumonia, and that means that the patient is going to stay in hospital longer. Instead, if you aggressively manage the chest drain, but properly, then all the recovery of your patient can be significantly improved and having a direct impact on the quality of life of your patient, which are measurement in a lot of the previous randomized controlled trial or single institution trials on drains are not very well considered. So what we have done to mitigate, and then my colleague Erin and Larsen are going to discuss more about countries and global, but we all started with a very old-fashioned analogic, moving to the digital drain. And if you look, there's very, very little evidence in terms of registry what are the differences in practice between countries. It's very difficult, even within the same cities like in London, to know exactly or to find a document where you can see if there's a lot of variability between the different institutions. So we tried to put some data together to have a starting point. And we managed to get 21 centers around the world and to collect over 3,000 patients. And of course, we look at the drain size, drain type, and specifically we look at prolonged air leak and how this affected our patient journey, and also look at some of the secondary outcomes related to the prolonged air leak, such as surgical emphysema, drain-related complication, length of stay, and readmission. And when you look at the center, so some data which we're very pleased that most of the patients, over 80%, they receive minimally invasive surgery. But when you look at the amount of air leak, is nearly 9%. So it's not an insignificant problem that we have to address. And majority of our patients have VATS surgery. Majority, they had a lobectomy and anatomical lung resection. But as you see, there's an incredible variability in terms of use of the digital system, from less than 5% to over 90%. The drain size varies from 20 to 32 French. The suction, use or not, is between 8 to over 80%. And then when we specifically look at predictors of prolonged air leak, what really is really interesting is that the increased risk of having a prolonged air leak is related to the digital drain system, probably because it's more precise in detecting even smaller leak that we can miss with the analogic drain. And maybe we are scared to remove the drain when you have 10 or 20 mils of air leak. But also what is protective is the drain size. So smaller drain you have, and more likely you can have a prolonged air leak. But not only this, when you specifically look at the drain size, you also see that the surgical emphysema and possible drain reinsertion was higher with smaller drain. And I think this is only related to physics, because the smaller drain most likely cannot detect a small air leak just because the drain is surrounded by all the lung parenchyma and it can just kind of get blocked. And we can miss some of those data. So when we specifically look at these events, then we notice that every drain below 20 French, they have an increased risk of those complications. This is why we thought that a 24-20 HS drain is safe to use. And we didn't notice a specific increase of pain. Of course, because it's a registry and covers different countries, very difficult to balance for the cultural difference, and we didn't have a pain score for those patients. So when you look at the digital uptake again, you can see that in terms of pulmonary complication, the recorded prolonged air leak was higher in the digital arm. And when you compare digital versus analog, again, the same. You see that the digital had a higher number of air leak. So now the question is that, of course, we label as prolonged air leak because we didn't remove the drain. But when you go and look at the literature, there's a lot of paper that said that you can remove the drain when you have a small air leak, 10 to 20. And as a disclosure, I'm one of the surgeons not removing the drain when you see an air leak of 20. But are we right or wrong? Well, maybe if you combine those two data, so what is being published so far, and the fact that you have a higher proportion of patients with more air leak in the digital group, probably both slides are right. So we, yes, see more air leak, but they are quite or undetectable air leak on an analogic system, and those should be taken out. So what is the patient's outcome related? What is important? All of these, because the digital chest drain system can give us more consistency when we focus on the patient journey and the quality of life after the operations, be able to have a more objective measurement, have a look at the trend, and be then able to remove the drain aggressively, but in a safe way. But despite all of that, we are still behind because not many studies confirm the advantage of the digital drain, despite more and more we try to use the digital drain. So just to conclude my presentation, I think there's still a high variability in chest drain management, even within the same countries. The standardized drain management can significantly improve not only the standard outcome we analyze, but the patient-related outcome. And digital drain can play a key role in improving the patient-related outcome. But of course, we need to design more rigid protocol based on real-world data and patient's experience. And I want to thank all the centers who contributed to this registry. Thank you very much.
Great. So we're going from data to pathways. And next we have Lars Ginnen from the Netherlands talking to us about how to create standardized drain management pathways within his hospital and country.
Yeah, thank you, Eric, for the introduction. My name is Lars Ginnen, PG candidate in Zuidland Medical Center. I'm not a surgeon yet, but hopefully I will be in a couple of years. But I would like to thank Medela for the opportunity to talk to you and with you about our experience in creating standardized drain management pathways. But first I would like to introduce our team in our Zuidland Medical Center. We are a large teaching hospital in the southern part of the Netherlands. It's the only hospital in the Netherlands who's accredited by the ESTS. We perform a wide range of thoracic procedures with approximately 110 anatomical lung resection. And our team consists of 3 dedicated surgeons, PhD candidates and research managers and data managers. So now our road to progressive chest drain management, and it starts with the guidelines, the ESTS guidelines and the STS guidelines. And they are quite clear in what they think about the drain. It's still placed routinely after lung resection, but most of the recommendations have low evidence, conflicting data, and are based on expert consensus. So at one point we were start thinking, are we treating the patient safe, or are we doing what's the best for the patient? So we start thinking outside the ERAS box, and this led to a couple of questions, quite practical questions. Can we remove the drain earlier? Do all patients need a drain? And are we sometimes over-treating a patient? So, and with overthinking ourselves, we were thinking, are we the only ones in the Netherlands? So we initiated a survey among Dutch lung surgeons. And one of the first questions was, how do you rate your own approach regarding the drain management? And interestingly, around 65% of the respondents see their approach as progressive or very progressive. But if we look to key elements of drain management, there is a huge variability. As you can see, for example, the fluid volume, the threshold of that differs a lot, but also the time of drain removal. But at the same survey, we asked them, what is the reason for you to use progressive drain management? And shorter length of hospital stay, patient comfort, and enhancement of the ERAS protocol are consistently used. So with all this variation, we realized we don't need a radical change, but rather a gradual one. So step by step, and the first step for us was earlier drain removal. And for that, we implement the Topaz drainage system to make our decision-making more objective. And we defined new removal criteria. And we use an air leak below 40 milliliters per minute no threshold for fluid output, and a drain can be removed at the same day as surgery. So now we can go to the next step, and the next step is drain omission after wedge resection. In the same survey as I mentioned before, we asked the surgeons, do you perform wedge resection without a chest drain? And only 30% of the Dutch surgeons who responded do perform wedge resection, and it ranged between 10 and 100% of their wedge resection, despite clear evidence. In a meta-analysis of our center, we found that drain omission is safe in wedge resection, and it reduced the hospital stay by 1 day. And we looked at our own internal data, and we found the same pattern. So we saw no increase of major complication, and the hospital stay was reduced with 1 day. So that makes us go to the third step. Third step is, can we omit a drain after anatomical lung resection? The same survey, just 3% of the respondents, there were 59 respondents, said, well, we do omit a drain after anatomical lung resection in selected cases. But in our own data, we see in all our anatomical lung resection, we see that 61% of the patients do not have a significant air leak after 1 hour. Significant means below 40 milliliters per minute. So are we treating a patient because of routine, or are we maybe over-treating the patients? So we started a small cohort study since September 2025, and we had 16 anatomical lung resection without the chest drain, and we saw postoperative outcomes, length of stay, same day discharge to 2 days. We had 1 drain reinjection due to subcutaneous emphysema, and 4 readmissions, but they are all non-drain related. And we used the Topaz to check and to make it an objective during surgery if we could do drain omission in the patient. So the next step for us will be this feasibility study. Within 2 weeks we will start this study. We need 85 patients, and we're trying to omit the drain after anatomical lung resection. We used the Topaz data intraoperatively, so we connect the Topaz drain, and if the air leak is after closure below 20 milliliters per minute, we remove the drain at the operation room. If it's above the 20 milliliters, well, we detubate or extubate the patient, and if the patient is awake with spontaneous breathing, we do another assessment, and if it's below 20 milliliters again, then we remove the drain at the operating room. So from exploration to implementation. But implementing and progressive management, it comes with challenges, and this was the last question of our survey. It's a case presentation, and it was a quite straightforward case. So a patient undergoing an anatomical lung resection with no significant comorbidities, no complication intraoperative, and no air leak. Do you still place a drain? And 16 of the respondents said no, we can omit the drain. But there are quite a lot of reasons to place a drain for the respondents. So there are clinical reasons, unforeseen delayed air leak, or the risk of the placement of a drain in an awake patient, but also non-clinical reasons, just habits or the peace of mind of the healthcare providers. So the decision making is not only a clinical one, it's also the habits and the routine of the healthcare takers. In a study by von Meijeveld et al., they elucidate the potential barriers and facilitators for implementing new protocols. And They saw a variety of barriers and facilitators, but I think the most important one is a poor communication as a potential barrier. And as facilitator, it's a multidisciplinary team, including a senior clinician as leadership, and a broad support to adopt the protocol. So the take-home message is progressive chest drain strategies are feasible and safe. Many patients are overtreated with standard drain placement, but we have to go step by step. Challenges are mainly behavioural, so we do need to get used to another routine, and success requires team engagement and clear protocols. So I would like to thank Medela again for the opportunity to talk to you about our experience of drain management. So thank you.
Great, thank you very much. So I'm going to take on the next talk, and I think it's really nice to see it getting progressively wider and more global as we talk now about transforming data and pathway into value-based care. And here are some of my disclosures, and obviously the ones in red are with Medela. First question I'm going to ask you is, when you see an ERS guideline, 66 recommendations, you naturally assume, right, every recommendation is equally important, right? You see is that right? You see 66 recommendations, they're all equally important. But what we don't know, or we don't see, is that they are never equal. They are never, ever equal. Checking a person's full blood count before surgery is not the same as managing a patient using VATS lobectomy. So the weight and impact of each recommendation is different. When we broke down the number of factors of what keeps people in hospital, what we can do is a regression analysis, and we can see that by far the duration of drain has the biggest impact, tenfold compared to any other, including VATS lobectomy versus thoracotomy. The management of the drain is even more impactful on keeping a patient in hospital. And this very simple reason is because when a patient's in hospital, surgeons are very reluctant to send them home. They like to pull the drain and send them home. So it doesn't matter if you do a VATS or thoracotomy or something amazing operation, you did robotics, you did single port robotics, at the end of the day, the drain's there, you don't send the patient home. That's why the drain and not the robot has the biggest impact on whether a patient goes home. Now, you may know me as a clinical trialist, and it may surprise you to say that actually drain is an area, or drain management, which I don't think you need a clinical trial for. And I really am very grateful for Ken Suzuki's trial that he presented today at the 8 o'clock session, showing that fluid doesn't matter. For me, I used a different prospective design similar to a dose de-escalation study. For example, if paracetamol 1 gram works, does 500 milligram works? If 500 milligram works, there's 400, and we keep on going down. So the equivalent for the drain study is, if you have if you have fluid criteria, is 3 mils per kilo safe? And if so, is 4 mils per kilo safe? And progressively, I went up by 1 mil each year to find out that ultimately, at the end of the day, the volume of the drain actually doesn't matter. And then we published a series of over 800 patients demonstrating the safety when you have no fluid criteria. So the reintervention rate was 2%. It's not everything has risks and balances. But you can see from a randomized controlled trial, for which they randomized 300 patients into no fluid criteria versus fluid criteria. In this case, we have data or safety on over 800 patients in a very short span of time. So for me, I prefer that to the randomized controlled trial design. Now, why should we even matter whether or not we can have a fluid or no fluid criteria? And the answer is because the fluid is a principal determinant of how long a drain stays in situ. So if you have very strict fluid criteria, it stays a long time, and you're very permissive, the vast majority are removed. And if you remove, you go home. because the drain protocol is the principal determinant for the length of stay. Now, the length of stay is very important because, and this is something that we don't actually think a lot about or discuss, but the cost per inpatient stay varies a lot, obviously, throughout England, United Kingdom, the United States, and the EU. Of course, the most expensive will always be America, right, because they're always so expensive for everything. When you leave drains in situ, which you don't need to, it's a resource. The medical doctors have to come and review the drain, the nurses have to take care of the drain. There's additional costs, dressing, documentation, time, all that takes up time, which then costs money. Digital drains have a higher capital cost, which means that you pay more initially for the outlay, but then the investment becomes very positive or favorable to return the money with time. There are randomized trials, and that was presented this morning at 8 o'clock, which showed this, but perhaps the best evidence, also showed by Jessica Donington this morning, was a health economic analysis done by basically the UK government, which is a very, very serious health economic modeling, showing that if the country all use topaz drains, on average, it won't cost the country any money. In fact, the country will save 8.9 million every year. And based on that, the UK government strongly recommended the Topaz Plus, and I believe that the vast majority, if not all the centers in the United Kingdom, are now using the Topaz Plus. When we look wider into the randomized controlled trials, and here's another problem, is that the reporting has been very inconsistent, and the numbers that they use are not quite easy to interpret. But all the trials show 1 day shorter hospital stay. What does that actually mean for health economics and the global implementation gap that comes along with it? 1 day saved is a big deal. Every unnecessary drain day occupied by a patient has a cumulative impact on a unit. If your unit does 1,000 operations, that's a potential saving of 1,000 bed days. Now, the NHS, if you say cost it at £500 per day, any unit doing 1,000 resections saves $500,000. That's a phenomenal amount. And that's on a standard 5-surgeon unit. Very often as surgeons, we don't think or care about the healthcare costs, which is completely escalating. Bed capacity is also quite a binding constraint. The drain-dependent discharge delays will reduce your throughput. And many hospitals, the prolonged length of stay doesn't generate any more income. What you need is new patients to come into the bed that you freed up to then generate more income. When you have excess bed days, the hospital ends up absorbing the excess costs. Globally, apparently AI thinks there's about 500,000 operations done a year around the world. And if you can reduce the drain or hospital length of stay by 2 or 3 days because of better drain management, then the aggregate sums are phenomenally, it's astounding, in the millions, if not billions, of dollars a year. Now, in high-income countries, reducing the length of stay will translate into billions of unnecessary costs to the actual healthcare system. And in middle to low-income countries, the prolonged admissions will displace other patients and consume a disproportionate amount of medical and nursing resource. Now, globally, digital drainage technology, I think, remains largely inaccessible, and we then always default to individual surgeons' clinical assessments. And we've seen from the first two speakers, I thought that was really interesting to see both the surveys showing so much discrepancy. And what I liked about Lars' conclusion is that the change is behavioral, and that's, for me, absolutely hitting the nail on the head. It's not about training. It's not about teaching you to be a better surgeon. It's not about buying new equipment even. It's about changing how you think improves care. Now, how amazing is that? If I hypnotize you and change all the way you think about drains, I'm going to improve care in each of your institution. Basically, is what it's saying, and I totally agree with that. I think investment in a standardized drain protocol, and that's the most important part, has already been proven to be highly cost-effective as per the UK NICE evaluation. But you can see that even though the national or international guidelines are recommending use of digital drains, use of permissive volumes, we just can't change practice. And you can see from last survey across the Netherlands, the vast discrepancy in practice. And why can't we change is the headache I'm always asking myself. And I think there's an autonomy culture, personal belief. Every surgeon thinks that he or she knows the best for their patient. They might say the evidence is weak, or you need to justify their ongoing practice, or maybe incorrectly identifying their case mix as different. They say, you know, I operate on really complex patients. You just have no idea or no clue how difficult my patient cohort is. And that's the kind of impression that you get from surgeons who are unwilling to change. But as an aggregate group, I think that if you don't understand the evidence empirically, it's really hard to make an independent assessment of the evidence per se. And for me, it's always been a bias towards the lack of statistical knowledge amongst the medical cohort. There's also a huge behavioral issue about risk aversion, in that people are concerned about what bad thing happens if I remove the drain too early, rather than what bad things happen if I keep the drain in for too long. So people are not thinking or framing their question or practice the correct way. The ESTS guidelines are great, but it's a guidelines without teeth. If you do nothing of those recommendations, nothing actually happens. No one comes to you, hits you on the head, or gives you a fine. Nothing actually happens. And also, there is a technology adoption gap because people are unaware of the cost savings on the long term that can result with an initial input. Where do we go from here? So this is going to be relatively controversial, and we've already broached this topic in the first few speakers, is do we even need chest drains at all? Not going to ask you this question because you know the answer already. Some surgeons are already putting up their hands that chest drains are not mandatory. Actually, I'm going to ask you again. Who thinks chest drains are mandatory for all operations? Really? I don't believe you. Who thinks we don't need chest drains as mandatory for all operations? Okay, fine. Good. So as we go on the journey, I like to think of it as a journey. First, we have a fluid journey, then we have an air leak journey, and then we reach the last stop of the train stop, which is the chest drain journey. Do you need actually chest drain at all? So here's the results of the first 100 patients where we pull the chest drains on table on all operations except anatomic lobectomy, and since then we've moved to anatomic lung resections, lobectomy, segmentectomy, so on and so forth. And you might go, what's the point? Why is Eric coming on stage telling us to do how amazing he is, how he's doing bigger and bigger things? Like, what's the big deal? And the big deal is we've achieved the first day case VATS lobectomy in October 24. And when you take the drains, in order to achieve day case surgery, you must first remove the drains on the table. And once we did that, this is the patient who actually had his operation the day before. He wasn't a postoperative day 1 discharge. He was a day 0 discharge. He went home on the evening of the operation. And we're able to replicate that going forward by changing the dogma that chest drains are actually required for all operations. So the next stage on the horizon is OPCATS. Optimum patient care for ambulatory thoracic surgery. So now we believe that the majority of thoracic surgical operations can be done as a day case operation. Now let that sink in for a while. Everybody, the majority going home on the same day, that thoracic surgery ultimately in the majority will become an ambulatory operation. In order to do this, we will need to be able to optimize drain management, and the aim is to eliminate the drain as the sole cause of hospital discharge. You're here because you have a drain? No, it doesn't really matter. You won't have a drain, or you can go home with a bottle. We want to empower our patients with the ability to choose when to return home, and also shorten length of stay. We already talked a little bit about the massive economic benefits. And we're going to pretty much include all patients undergoing lung surgery, pleural surgery, mediastinal pericardial surgery, as long as they can come back with a drain for review. We won't include patients with a massive air leak, more than 1,000. Pneumonectomies are a no, because in fact, we're probably going towards no drain for pneumonectomy in the near future. And if you have 2 drains because you're going to be in hospital, it's not manageable, very ambulatory. And I'm just going to show you a little peek about the data. And what's interesting to me is that the time frame is also the same as last, but from September to now, but we seem to have so much less patients. So we've got 5 surgeons taking part in this. And in this time frame, 175 patients were eligible, and guess what? 56% had no air leak. So this is already proof of concept. We know that the majority of patients that we operate on will not have an air leak. And if you follow protocol, then all those drains should have been removed in the 56%. But no, approximately half of the surgeons really were able to embrace the protocol to actually pull the drain out. And so only 88 out of 175 were managed on protocol, of which 57 had on-table drain removals. So coming back to Lars's point, it's the behavioral change that is the most difficult in the implementation of improved care. We calculated that that's led to a quantifiable 58 bed days saved, and if and when more surgeons take part in this, then that number is going to go up. We think this is proof of concept. The majority of thoracic procedures do not require a chest drain, and if that's the case, first, local implementation, national implementation, and finally global implementation is going to result in enormous healthcare savings, and all your institutions and all your countries are going to say thank you to me, and I'm going to say, oh, please, it's okay, it's me doing my job, you know? So in summary, there's evidence of shorter length of stay with digital drains reported by multiple randomized controlled trials. Data and established pathways have been developed to promote uniform drain management, but the uptake of digital drains and protocol adherence remains poor. Behavioral issues. The autonomous culture of surgery, I know best, I'm the surgeon, and is a direct impediment to improving patient care. Institutional healthcare global costs are going to go up because of this. And this is the background of all our countries having so little money for our healthcare systems that we really, as surgeons, should be trying our best to help the country go along. And ultimately, I think that we need to start learning to interpret evidence before significant change can happen. And it comes from within, I guess, as my beauty queen answer. And I've done a statistics course, again, to help promote the understanding and learning of statistics, because without that within you, it's difficult, if not impossible, to be able to implement any change or long-lasting change going on from here. Thank you very much. Great. So we're going to open the discussion to the audience now. And whilst you're thinking of questions, I've got one about the size of the drain. Often we ask or look to see what is the correct size of the drain. And for me, it's always been a physics issue. Basically, the flow is proportional to the fourth power of the size of the drain. And I love the graph that you showed, Andrea, where you had the problems as the drain, which goes down as the drain gets larger. And to me, that's not about what's the optimum size of drain. It measures the airflow of the range of flows across different operations. And therefore, like dose reduction in tablets, if a 32 will work, it will cover everything. Then a 24 or 28 will cover this much. 24 will cover this much. And as the drain size gets smaller, it's the fourth power of the radius, so it's a simple physics problem. Do you think we still need randomized controlled trials, or should surgeons just guess one size for which they think will cover the majority of air leaks for their practice?
I don't think we need a randomized control trial. I think it's physics, and you just need to decide what is the size of the drain can cover majority of the problem we can encounter, and I think that has to be a decision you take at the time of surgery. Again, we don't have to be fixated, or, I always use a 32. No, sometimes you can use a 24, but if you have a bigger leak at the end of operations, you know that the 24 may not be enough to drain by physics all the air that is going to leak from the lungs. So I think, that graph shows you that you need to be flexible and take the decision about the right size at the right time.
Okay. And another question for you. Some people say a bigger drain is bigger pain. Do you think that the drain itself causes the pain, is the principal issue, or the surgeons don't do a good enough intercostal block?
I think is an excellent question. I do believe is more like related the way you do the block.
Yeah.
And sometimes also is the drain position. What I found that, You see some on chest X-ray the drain really apically irritating the top pleural when you have your brachial plexus, then it's causing a lot of pain. But I don't think if we downsize everything from 28 to 24, we resolve the problem of the pain. It's the way we block the nerve, the way we give the perioperative analgesia makes the difference rather than, because 24 to 28 French is a minimal incremental in terms of millimeter, not enough to justify a mechanical compression of the nerve.
Thank you. Lars, I like your presentation. The last slide was about you surveyed the surgeons once, and then you told them this is how it is, and you surveyed again to see would you actually change your practice, and a lot of them actually wouldn't actually change. How would you go about trying to convince or educate the surgeons in your country as well as in the room whether or not they would change their practice?
Well, I think they will change, but they need evidence to change. So hopefully with the study we will start within 2 weeks, they will get evidence and they will see that it's safe and feasible, and they will start changing. But without evidence, they won't change, I think.
Yeah, I mean, I am so hoping that you're right, because I did the same presentation in an institution, and here's the evidence, and here's the protocol, and everyone's like, yeah, but no. So the step between they will do it, or you're expecting people to do it, and people actually doing it, I think it's a massive chasm. It's so huge. A question from the floor. It will work in 2 seconds. There we go.
Oh, thank you. I'm Marcin Sackowski from Warsaw, Poland. I'm a resident. Thank you for your great session. I'm trying to remove drains earlier, and sometimes my older colleagues get angry with that. I have because we discussed like two dimensions of the drain removal, the fluid and the air leak. I have a question. What about findings of chest X-ray, like example, residual space or fluid collection, like the drain is in the apex and the fluid collection is at the bottom of the pleura? How do you manage with that, with the aerial removal of the drains?
Andrea, you want to?
Again, I think that we are treating patient, not chest X-ray. So if it's a small space and the patient is comfortable, you can still take the drain out. Of course, if there's no any air leak, otherwise you have to keep it. And the same for the fluid at the bottom. What is the type of the fluid? Is hemorrhagic, then probably you have to keep the drain. But if it's a small amount of fluid and the patient is comfortable and it meets the output drainage criteria of your institution, I think you can take it out. So I look less and less at the chest X-ray. I think that sometimes we do, because again, it's our comfort zone. We always like to have some reassurance, but do we really need all this reassurance? Probably not.
Yeah, I probably would add to that. It's interesting that with the advent of digital drains, it's taught us to interpret X-rays very differently as well. So if the drain is patent, and if there is a pneumothorax and the air leak is 0, that is not pneumothorax as you see it. It's just a fixed space. That means the lung is stiff. It hasn't come up to fill the space at all. And for me, we probably wouldn't see that because we would have pulled the drain out on table already, because the air leak, it was 0 mils per minute. But we are very, very confident that we don't need to do anything. Because what digital drains has taught me is that there's a difference between a pneumothorax and an ongoing air leak. And if there is no ongoing air leak, 0 mils per minute, it doesn't matter what you see on the X-ray, there is no active air leak. So by the law of physics, it will resolve at about 1 millimeter per day. One interesting story is that before we pulled the drains out on table, we audited the nurses doing it on the wards, and they had a pneumothorax rate of about 12%. And we thought, as surgeons, we're going to pull it on table, it's going to be amazing, the results are much better. And the surgical rate is 20%, 2-0. So we accept a 20% pneumothorax rate, but we know there's no air leak. It's okay to have a pneumothorax. Can you add to that, Lars?
Yeah, but do you perform X-ray after drain omission?
Yeah.
And just to follow up or see complication, or why?
No reason. And this is a very, right, Mr. Evidence, very controversial area where people say, pull the drain, man, you don't need an X-ray. Great. But the X-ray is I mean, for me, is a very low intervention in terms of, not very expensive, so on and so forth. And it just gives a baseline of what happens in the future going forward. So that's why at my institution, actually we do an X-ray on coming to recovery, and we usually do an X-ray post-drain removal about 4 hours later.
Thank you.
Yes, please come to the stage. Oh, come anyway, because it's recorded, so we are going to...
question for you, Eric.
Yeah. You want to introduce yourself, Perry?
Talk. Perry, I work in the UK. When you say on the table, I had patients more than what I
Can
would
you play the video, please, on table drain removal, just to show you how we do it? And also, yeah, so please carry on.
Sometimes even in patients with really good anatomy, you finish the operation, you don't expect any air leak at all, you put the drain in, they're still on the side, and you measure an airflow 40, 50, 60, sometimes even more. And the air leak comes down to zero only after the patient is turned on their back, extubated, and taken to recovery like 10 minutes later. So what do you define as on the table? And what do you think would be, if you were to generalize this practice of removing the drain after surgery, how could we maybe try to capture what the safe time would be? Because it really, I don't understand why it measures flow, but I've seen it in more times than what I would have wanted to. Even if you're absolutely convinced you're looking at the lung, there should not be any leak from anywhere. You still measure a flow from the turbines.
Yep. So I'm going to answer half the question, and Lars is going to answer the second half. Because we decided over dinner last night, how we're going to address your question, Perry, because we predicted it. The simple matter for me is we have a strict drain protocol. If it's not 0 or 10, we cannot pull the drain. And that is a really annoying subset of 30, 40, 50, which we allow them to go back into recovery, and then we see 0, and then we pull the drains out the next day. And the solution is, Lars?
Yeah, so we included a second time measurement. We check it during surgery, after closure, patients intubated with 5 PEEP, and if the air leak is below 20, we remove the drain, otherwise it remains in situ. Then we detubate the patient with spontaneous breathing, and if the air leak is below 20, we pull the drain. So
they have a two-step process, which I think is really, really clever, which is for that annoying subgroup of 30-40s, which then go down to 0 in recovery, they preempt it by putting the patient on spontaneous ventilation. So they wait a little bit longer. For me, I'm in the coffee room already, so my team will have to sort that out. But I thought that was a very good idea, and we probably will implement that. So once you're spontaneously breathing, and if you go down to 0 or 10 fulfilling our criteria, then we should just pull the drain out as well. This is a video about how we do the on-table drain removals. And one of the things we wanted to show as well, I feel as if I'm a very frustrated cosmetic surgeon. I love to have a beautiful cosmetic result for the operation. And then one of the benefits of having on-table drain removal is that you can get a very beautiful scar. It's like completely flush. And people may ask, how do you do it? There are 2 components to this. If you notice, the drain anchoring stitch is not on the skin at all. The drain anchoring stitch, we anchor it in the subcut tissue, so there's no additional scar from that. Then we do a subcuticular layer whilst waiting for the air leak to go down, and we sew the incision as if the drain is not there, and we'll show you how we do it. And when we pull the drain, we pull the incision flush, and it comes out really beautiful, very cosmetic incision that you can go on the front cover of any magazine that you like, male or female, without any worries. Another question that a lot of people ask is, how long do you wait for the drain to settle? And you'll see from here that it settles on its own. It converges to 0. You see that? It just went to 0. It doesn't go from 0 to 100 and back again. It just goes to 0 and it stays there in general. So this is how we close the wound as if the drain is not there. We sew on both sides. And if you're wondering who's doing the excellent stitching, it's not me. I've trained a series of specialist thoracic nurses from scratch, and this is the hands of one of our trained thoracic nurses who had 0 theatre experience. So we train a whole group of thoracic surgical nurses to help us in our theatres to ensure that the actual quality is always maintained. I put the little forceps in there because what we learned when we do the on-table drain removal is sometimes the drain hole catches in the stitch and the drain gets stuck, and that was so painful. But once you pull it out, you get a very flush closure, and there you go. That's kind of how we do it. So the patient loves it, we love it, and then we check the X-ray in recovery. Any other questions from the floor? Yes. And look at that amazing X-ray, no pneumothorax. How good are we?
Hi, thank you for a perfect presentation. I have two questions. First question is, are you convenient with the results of colleagues from China who practice non-tubeless procedures and they operate without chest drains and in Guangzhou and something like this?
Yeah, yes, I'm very aware of that. And it's interesting, the Chinese guidelines, like what you guys are doing with that little underwater bowl, which is so strange, right? Because if you go up and down, the pressure is different, and the bowl to me looks a bit weird, or you might spill it, or we do the same thing, but we use a topaz drain. We quantify 0, we can actually document that it's 0, we measure the air leak. So the OPCATS program is all about tubeless surgery, no chest drains. So that's what we want to implement. But as our speakers here have already highlighted, it's a behavioral change. It's not just saying, hey, this is better. People, just because you say it's better, people won't actually take it up.
They perform some operations completely without, so for example, the wedge resections and some anatomical resections. Do you see the thresholds, for example, so we can make this type of operation completely without drains, and for some operations it's mandatory? I mean that.
So I don't think it's reliable because what you think, underwater, we obviously put the water in and then we test for air leak. But the topaz is much more sensitive than that. So we put the underwater thing and we say, oh, there's no air leak. We put a topaz in, there's like 30 mils. So I personally don't think it's safe to just not put any drain in. And the second downside of that is if you don't put any drain in, firstly, you can't predict who does and who doesn't, or who won't have a pneumothorax. Even if they don't have an ongoing air leak, when they push out all the air in the thoracic cavity, when they're extubated, you end up getting surgical emphysema. What's your thought about completely drainless?
I agree with you. I think that, again, for example, we believe in the topaz, so I don't do any water test except for like pneumonectomy or sleeve. But I think not leaving the drain, when the lung is going to re-expand, again, by physics, there will be some air within your chest cavity is going to escape, and then you will have surgical emphysema, can be detected on X-ray. And we know that on the X-ray, the surgical emphysema gets worse in 2 or 3 days because the air is migrating up. So then you have to treat the X-ray what you find, and you may avoid all this problem with a simple intervention, leaving the drain for 1 minute, 2 minutes, and the drain is not going to harm your patients because, again, you don't have to do an extra hole to put the drain. So I still think that it's better to leave a drain when the lung is expanding and take it out when the wound is pretty much closed.
No, the procedure is a little bit, as I understand, is another way. So at the end of the operation, the surgeon put the chest drain, and after the rotation, the chest drain would be deleted, and for some operations it could be mandatory. For example, for wedge resection and for some complicated anatomical resection, it's questionable, or discussable. I mean that way, but it's not the situation. So you put it's not the dealing with the way of probe. I mean that.
I don't have any experience in that. I always put a drain in. I always assess the air leak, even though it's a thymic operation. I haven't touched the lung. At some point, you may have accidentally breached it, and then you get an air leak. So I always test it.
And the second question, for your personnel, Professor Lim, there's a threshold for 20 milliliter per minute. What do you think the realistic threshold for chest drain management? For example, the colleague from Switzerland, he suggested a 40. And sometimes we see it's totally normally when we see a little bit progressive pneumothorax, but without expanding component, and yeah, it's okay. So in a couple of days it would be resolved. What do you think it would be the good measurement, a good number for leakage?
So that's an interesting question, and the simple answer is it's up to you to define. So if you can do 20, 40, you can do 60, 80, 100. You can do whatever you like. The real question is, what is the rate of unacceptable pneumothorax that happens? Because as you increase the number, you will just from physics increase the number of pneumothorax and drain reinsertions. And for us, we started out with 40 actually, and went down to 20 and then below 20, because when we first started at 40, the drain reinsertion rate we felt was unacceptably high, or the complication rate was unacceptably high. We know that more than 50% of patients don't have an air leak after surgery. And so we're quite happy using a smaller threshold because we don't want them to have any issues post-op. So that was my own personal risk aversion, which is about maybe 2% of drain reinsertion. I wasn't happy with that. What do you use?
Normally it's about, again, 10 to 20. We don't go above 20. I agree with Eric, it's institutional. We know there's a certain degree of air leak can be reabsorbed by the pleura, but there's no, again, we don't have any clear measurement to say 40 maybe better than 20, or if there's any patient where 40 works better than 20. I think that has to be tested. But as soon as you see that the number of drain that you have to reinsert is higher, I think you very carefully have to reevaluate your threshold and go down.
Thank you. Oh, yes.
Sorry, it's Elizabeth Sander from Ghent University Hospital. I just have a question. Do you change your follow-up protocol if patients have an early drain removal? So if you would say you remove the drain during surgery, you do an X-ray 4 hours after, they go home. When do you see them back in clinic, and do you do an X-ray or you don't? So
for my own practice, we take the drain out on the table, we have an X-ray in recovery, and then they may go home on the same day, or they may go home the next day, and then we see them 1 week later in clinic with an X-ray. That's what we do. Any other questions? So I've got a final question for you then. How many of you who have actually attended this session today feel as if you would consider making a change to your drain protocol at work? Hands up. Wow, oh my God, you guys are amazing. Thank you so much for coming. Thank you to our speakers as well, Andrea Bille, you got Lars Gienen, and myself, Eric Lim. Have an amazing day. I'm glad we have actually made some change to your practice and progress. Thank you so much.
Thank you very much.